Welcome to another episode of Stories from the Edge of Life. We have once again a very special guest, Dr. Daniel Hofer. Hi, Dr. Hofer.
Hello, Parag. How are you doing?
Very good, thank you. Would you mind introducing yourself to our audience, please?
Sure. I'm Dr. Daniel Hoefer. I'm the Chief Medical Officer for Outpatient Palliative Medicine at Sharp Healthcare. I'm a family physician at Sharp Steele, and I'm the Medical Director for Sharp Hospice Care. I've been in practice at this medical group for 30 years, and I started my career in healthcare in 1986. Not sure how much more you want, but that's probably
that's a lot. Very impressive. Thank you. And I'm Parag Bharadwaj. I'm a hospice and palliative medicine physician. So, Dr. Hofer, wow, you wear a lot of different hats. And tell us about what was it like when it comes to practicing medicine in the 80s and because not everybody is very familiar even today with palliative medicine. What was the
you
environment like then in terms of
That's a great question. We could talk the whole half hour just about that. But back in the 80s and 90s, before the Patient Self-Determination Act, when you were working in the hospital and somebody got dropped off, we told the patient and family what the patient's going to get. The patient didn't have a whole lot of control. And we kind of just said, this is standard of care. And it was a great tumultuous time about, do patients have the right to make decisions about advanced illness and end of life care. And I remember to this day, the first patient that we resuscitated when I was an intern, he was probably an 80-pound, 90-year-old demented patient who coded. And the chief resident said, well, we know who this is. We're going to walk slowly up the stairs and hopefully she'll flatline before we get there. And she didn't. And we all got to practice running a code. And I was up there doing compressions, and I can still feel cracking every single rib as we compressed her heart and brutalized this patient at her end of life. And it was horrifying. It was not a good experience. And there's many points I can think of, but that's the one that popped to mind when you asked that question about the old days. It doesn't mean that doctors and nurses and hospitals weren't compassionate. It was just a different era. We had different rules. And it took an evolution of time, a culture change over years. And we're not done, by the way. I'm sure you are aware of that. But we are only a third of the way through that process to getting to where we need to be, in my opinion.
great. So could you contrast that with what that would look like in today's environment?
Well, in today's environment, you still hope that people have code status. And then, even more importantly, you hope they have a code status that's consistent with their goals of care. And most importantly, too, is then you have to ask the question, do they even want to be in the hospital? Among another dozen questions that don't get asked enough because we're more technically oriented about the management of the disease and then instead of the management of the human being behind that disease. And we have to remember that our population is aging and the risks of hospitalizations and procedures are markedly higher than they used to be at a younger and healthier age. I don't want to be too scientific, but the recent study from the National Health and Aging Trends showed that 30% of our patients will not come out cognitively or functionally the same. They'll be worse off when they go for surgery over the age of 65. And that's not a step like a step ladder. That is a gradual increase. So the older the patient gets, the less likely you are to perform a procedure or hospitalize a patient without them having some form of cognitive or functional damage. That's a constant conversation that needs to be happening between their physicians and their patients as to whether the intervention risk is worth the benefit. And I don't think that conversation is being had enough. I think it's right up the alley of palliative care providers to help physicians and other providers with that conversation. But those are, we shouldn't be managing disease. We should be managing human beings. And we should be helping them to live the best lives that they can. But we can't know what that is until we know what they want, unless they can have the tools to make the value equation that they see fit for themselves. And then we have to be tolerant of decisions that may not have been what we chose. And that's very, very hard for some people.
Thank you. That's very eloquently put. And that description of the code that you gave, on that when you ran that code, it's very different from what we see or what people typically have as an impression of, CPR. You watch TV, um, and hey, something happens to the heart. They come in and they shock the heart, and the patient is back to normal. I mean, that doesn't happen quite often, especially with the elderly. Could you just comment on your views in terms of, uh, I would call it fiction versus reality?
Yes. Well, it's heroic. The original intent of resuscitation was for drowning victims, and a couple of other minor uses. We expanded it to everybody and everything. So it's a little bit good. More is better. And it turns out everybody was getting resuscitated, whether it was a good idea or not. And as we know, some people, they just don't survive well. It approaches 0% survival in some advanced elderly populations. And so, but we still perform or offer the option of resuscitation, even though it's completely futile. That's problem number one, because just having a beating heart afterwards is one thing. But what about the humanity of the person behind that once they have recovered? And that's a conversation that's not even started yet. So if you get those very low statistical probabilities of survival that decrease as somebody gets older, it's 5% if it's not witnessed and 10% if it is. But for every minute, your probability of survival goes down another 5 or 10%. But we also don't talk about that if they do survive, the cognitive abilities and functional abilities may be deteriorated and gone. And to some, and we hear this all the time, and I've been practicing as a primary care physician, and I have these conversations, and my patients look at me, Parag, and they say, well, Dr. Hoefer, when my time comes, please don't get in the way. And that's what they're asking us, don't get in the way. They're not asking to be resuscitated. They're asking us, don't get in the way. Just let them die a natural death and keep them comfortable, support their loved ones, support their family in the process, make it a beautiful experience instead of a devastating, traumatic experience. And we can move away from that. And you know what? For all the people who say, I want to have a resuscitation and a traumatic experience, fine, I'm totally for that. But there are many, many people who choose an alternative pathway, and that's what we need to be. We need to be tolerant of all people. And I have one of my favorite sayings, Rica es un mundo. My mom said the family's from Mexico, and it says, every head is a world. And so if you presume you have one solution for every head, you're probably not doing your best job.
Very well put. Now, you mentioned that there's an alternate, right? It doesn't have to be very drastic, and it can be very beautiful. Can you describe
Yes.
that aspect? When you describe it can be beautiful, can you give our audience a description of what that could look like?
I can tell you that my mother-in-law just had a beautiful experience. My mother-in-law is from Thailand. She's 80 years old. She'd been having abdominal discomfort for 2 years. They'd done CAT scans, ultrasounds, laboratories. And one day, for whatever reason, my mother-in-law said, I think I have cancer. I need another ultrasound. They did an ultrasound, found a mass in her abdomen, then did a CAT scan, and there was metastatic, most likely liver or cholangiocarcinoma. And to the contrary opinion from her gastroenterologist, driving home in the car with my sister-in-law, my mother-in-law turned and said, I don't want to do anything. I've lived a beautiful life. I don't want to destroy that beautiful life by years of dwindling and chemotherapy and surgery. And I talked to my wife, and we translated over the phone what that meant. And they had just started palliative medicine in Thailand, which is fantastic, where my wife is from. So my sister-in-law found a palliative team. It was a very basic structure, a physician out of a hospital, a nurse came into the home, provided all of the standardized AHPM, NHPCO, CAPC, you can name them all of the great, fantastic standards of care, provided supportive care. And my wife flew back, helped guide the family, because my wife had been a volunteer for hospice and she knew what was coming and how. And I would call and tell my wife Yang what was coming next for my mom. She was kept out of pain. It almost brings me to tears because she had so many good stories about the simple things: combing her hair, being at home and her friends coming to visit, not being in a sterile environment where they're checking her blood pressure and doing things that are not necessary, and having her daughters take care of her hygiene instead of two nurses that didn't know her. And knowing that, when she had to get out of bed, she had to roll over to the side. So she scoot over to the side and roll over. These simple stories that made life meaningful for the last 3 to 4 months of her life until she finally passed. And it was just a beautiful, beautiful experience. And to me, that would have been much better than surgery. She didn't even do a biopsy. It was so obvious what she had. And I said, well, if you do the biopsy, you're starting down the pathway of going towards where physicians will want you to intervene and do more. I will tell you what that pathway looks like, and you can decide. We didn't tell her one way or the other. She made the decision. So no biopsy, no surgeries, no hospitalizations. Was kept comfortable at home for 3 months. She was well respected in her community. People would come to visit. She would say her respects, and she was able to say goodbye peacefully.
I'm glad she got the care, Dr. Hofer, and thanks for sharing that. It's a stark contrast of what you describe your experience to be when you were training. Um, I do have a question. It's fascinating. Like when we train, we of course, in during our careers, we've run many codes, but there's something about the first code.
Yes.
We never forget that one. And I mean, I remember my first code so vividly, where I tried so hard to save this patient's life. She was very young, had just delivered a child, and it was just a very intense social situation. But I didn't want my first patient to die, the first patient that I coded, right? And now looking back, I think, was it more about me than about the patient, right?
Thank you.
So yeah, and I think we have to always introspect in terms of um, what are we doing for the patient, what are guiding our recommendations. And so coming back to your mother-in-law, how did the family take it? Because sometimes the patients are more accepting of what's going on with them, but the family members have a very tough time. And often in your and my work, we see that to be a point of potential, I wouldn't call it conflict, but distress.
So I want to make two comments. Number one, I love what you just said. Um, and that is put to me in this phrase, because I'm always asking this question of myself as I treat my patients. And when I provide a treatment or a recommendation, I ask, who am I treating? Am I treating myself or am I treating the patient? You have to constantly ask that question to make sure that you're getting the best care possible. There's lots of standards in healthcare that are not based on the patient population that I deal with, in particular the advanced elderly that were deliberately excluded from research because they skew the results for the population that we treat. And so, when we're dealing with 5-star metrics for blood pressure or diabetes management or cholesterol management, we're holding them to standards for a younger and healthier population. And yes, I like to be rewarded for saying, well, I've got 90% of my diabetics under perfect control. However, it doesn't apply to this demographic. And so first question is always, who am I treating? Now, that second question you asked is, what about the family? And there was some discomfort because they'd never heard of this. They weren't used to this. They were used to sending people to the hospital. And that's what, other family members had gone to the hospital for other things. And when you're older, that's what you would normally do. But as you know, in many countries, um, it's just a default position. And it's a huge expense too for no improved benefit. And we talked about what that meant. She could absolutely go. We never said no. But my wife, who was there to explain, so that they didn't default to a culturalism, and we have many in this country, we default to using the emergency room, as a tool for decompensation care, and we default to putting people in the hospital at the end of life when there's no great purpose or additional benefit for that. And in fact, there may be harm. And it takes away a lot of opportunity. We feel better as providers because they're there and that's where we are. But the question is, do we even need to be a part of that part of their end of life experience when there are people who will go to the home? There are hospitalists, those are called hospice medical director, hospice physicians, and those physicians go in the home. They are hospitalists in the home. They are the specialists and they do a fantastic job, as do our nurse practitioners, our nurses, our social workers, our spiritual advisors. They are all our volunteers. They are specialists in managing this particular demographic, and it's not just the last 6 months, the last couple of years. So there was some cultural trauma, but it's the same one we have here because we're not used to thinking that the best place for the patient is not the hospital when they're in their moment of most need, but the best place is in their home receiving care there. And we got through it fairly quickly, though. It was easy. It was just one sister who was a little bit uncomfortable, but it wasn't long to get her back on board. Everything's been resolved. There's no residual from that. So.
Yeah, I'd just like to make a comment. Thanks for sharing that. Part of the reason why we started this was to increase awareness of our field, and how medicine is advancing and how patients have different choices that they can make. Because yes, there comes a point where the patient does not see any meaningful return on all the things that are being done to them, right? The interesting thing is that you actually bridged different cultures, right? So your family was very lucky that they had you as a resource and your wife. I actually I have a friend here who, his mother had cancer and didn't want to go to the hospital, and he wasn't sure as to what resources he has available to care for his mother at home. And that was in the US, in California. And so I think, to your point that you made in the beginning, there's a lot of ground to be covered.
Yeah.
In terms of understanding
Mm.
what really happens as patients confront and live with chronic diseases.
Yeah. And part of the problem in healthcare, to me, is that we fail to educate our providers into the multiple warning signs that a patient's approaching terminality, either disease-specific or non-specific warning signs. And so, and we worry too much about time prognostication instead of event prognostication. Time prognostication is, when is my mom going to die, versus event prognostication is, what's the next event in the expected series of events, and using anticipatory guidance to say, well, what does this patient, what does your mom, what does your family member want to do? Because that is the inevitable consequence for the vast majority of patients in the progression of illness. But there's basic tools. So when patients develop hospital-induced delirium, 80% won't be here in 3 years. What a great tool. That should be a trigger for every palliative consultation across the country. You develop hospital-induced delirium, there has to be some discussion because you've lost the stem cell-mediated ability to recuperate to a level you were before. Your body's starting to turn itself off. Unintended weight loss in the context of geriatric frailty, especially if you're 5 out of 5 frailty, sarcopenia, There's biomarkers. There's, if a patient has congestive heart failure and their intravascular volume depleted with a BUN of 50 and a creatinine of 2, and they have a BNP of 200 or 2000, we don't have to wonder what's coming next. I mean, I can't make it more concrete than that last example, but we sit and wait and say, well, okay, well, we'll just deal with it. The default position will be the hospital. Totally unnecessary. It's who we are. It's our culturalism. It's not a mandate to practice that way. It's just the history of the acute care model of disease. And so we can change that, but it's slow in coming. It is changing. That's why I said we're about a third of the way there, but we have got a long way to go.
As you were describing it, I was just thinking, denial is a very strong mechanism. And, sometimes as physicians, we might be in denial in terms of, okay, we've overcome a hump in the patient's journey. And then, like you said, then all we are doing is waiting for another event to occur. And we need to be prepared for it. We need to let the
Right.
family and the patients be informed and in terms of what's to come. So yeah, very different take on how medicine is being practiced these days, and thanks to leaders like yourself, we now are able to move the needle in terms of the care that is being provided to patients. So I'm personally aware of the impact that you have made, and it's very humbling. And I'm sure uh, when you started off your career, uh, things were not as easy as they were when somebody like me started looking into this as a career option. So could you just share your 2 cents in terms of that particular transition that you've seen over the years before we wind up?
Well, there's been a lot of changes. There was a rite of passage in healthcare, and you had to go through your residency and be on call every third night, and you were up for 36 hours at a time. And although there was a sense of heroism when you were young and healthy and doing your internship or your second year, you'd deliver a baby, you'd resuscitate somebody running a code, and take out a gallbladder, and you're all doing this. I was in a private hospital for a family physician, and so we did it all, and it was great. But I think that the evolution of having all of the hospitalists and specialists and SNFists or sniffologists, I don't know what they want to be called yet. I hear it both ways, and the isolations are now family physicians and internists. We generally just stay in the office. We've lost the bigger picture, and I think we're better able to tolerate a long career because it's not as brutal for such a short period of time. It's also perhaps less rewarding. I don't work in the NICU anymore. When I had 4 patients in the hospital, they could be in 4 different hospitals. So adult hospitals, pediatric, and the women's hospital. But now we've isolated ourselves to staying in our silo, and it is more efficient. And I think there is some ethics to being more efficient in managing populations, because we're going to need more and more doctors for the number of patients that are coming, especially elderly patients that have more visits. But I think my biggest concern about the future in the way things have changed is that there are less people who follow their patient from birth through the hospital, through their grandparents being hospitalized, going through the nursing home, then to home health, and to hospice, and then passing away. I don't think you see that family continuity. I don't think you see that transition from facility to facility. We've been siloed in spaces, and so you can't feel. You may understand it's there, but you don't feel what happens to your patient when they're admitted to the hospital and then sent to a nursing home. And then they go home and they go through that revolving door as if it's just the inevitability of the process. And I think that's something that we need to retain our awareness, and we need to practice across timelines and practice across cultures. and practice across silos. And that's a big ask in this environment.
Wow, that's yeah, it is a big ask, and but I think things are moving, so that gives me optimism. And so yes, thank you so much for sharing your insights and walking us through the evolution, which is still ongoing, like you mentioned, of medicine. And I think we are living through some great times in terms of the advancements being made, but they do come with their own challenges. And uh, but we keep marching on.
We keep doing it. I'll keep doing it. You're going to keep doing it. It'll keep going.
Well, thank you very much, and I hope to have you again soon.
Great. Absolutely, Parag. You have a nice day.